This conference will now be recorded.
Today we are going to discuss about blood and blood products transfusion. Most of these questions which you will come across in your regular practice and also in your short notes questions. So coming to the introduction part, blood transfusion means it could be transfusion of either the whole blood or separately components, just like fresh frozen plasma or platelets alone in case of dengue and other coagulopathies. So either a complete transfusion of a whole blood or its components from one person to another. So coming to the history part, this you could, one of the most important points which you need to highlight is in the year 1901, Carl Landsteiner is the one who discovered blood group, the ABO compatibility system, includes blood groups A, B, O, and AB. So after that, there is widespread acceptance of blood transfusion due to the efforts of the Red Cross system, and later in 1939, rhesus antigen, which is either positive or negative, mostly positive, was identified as prior to that, blood transfusions were matched based upon ABO compatibility, and then RH positive and RH negative compatibility was also seen. So coming to the composition of blood, 55% of it is composed of plasma and 45% is cells, and various inorganic and organic components are also present. So plasma, it is a star-colored fluid which contains plasma proteins, which helps in the transport of various hormones and other physiological molecules, along with maintenance of oncotic pressure. So most important proteins in plasma is albumin and globulin. So suppose if you order a serum protein analysis for your case of any suspected syndrome, nephrotic syndromes and all, you will assess the albumin globulin and the AG ratio, which is quite significant in proteinopathies, and fibrinogen, which is the precursor of fibrin, which plays an important role in the clotting pathway, and there are regulatory and protective proteins. So chemical messengers for endocrine glands and antibodies, all these are present in plasma. Coming to the cellular component, there are WBCs, RBCs, and platelets. And in inorganic substances, there are ions like calcium, magnesium, potassium, sodium. Organic substances were excretory materials like urea, uric acid, and bilirubin, etc. So blood cell types, if you look at this comparative table, RBC, the WBC count is normally 4 to 4.5 to 11,000 per milliliter, and platelets 1.5 to 4.5 lakhs, hematocrit 40 to 50%, which is comparatively more in men percentage. Hemoglobin comparatively more in men. So if you look at the differential count in WBC analysis, most often the percentage out of the total percentage, neutrophils forms a major component, 40 to 60%, lymphocytes 20 to 40%, and Its eosinophils 1 to 2%, basophils of the least component is 0.5 to 1, and eosinophils are elevated in case of any allergic syndromes and all, so such as like eosinophilic esophagitis and any allergic conditions, non-allergic fevers, hay fevers, etc. So coming to the transfusion of blood products, whole blood means nowadays transfusion of whole blood is regarded as an inefficient use because of limited resources. Even after widespread information about the safety of blood transfusion and blood donation, mm, even nowadays blood products are generally scarce. So coming to the trauma surgery protocols and all, those people, the trauma surgeons pursued as transfusion of entire whole blood to a person is an inefficient use of limited resources. So, but the advantage is our packed cells, instead of separately transfusing only packed RBCs, the advantage is it also contains a coagulation factor, which has it also contains the plasma. Plasma contains proteins and all. So it is metabolically more active than the stored blood. So coming to the packed RBCs, in case of severe anemia, all blood products are spun down and concentrated packs of blood cells. Roughly each unit is approximately 330 ml, and its hematocrit is 50 to 70%. It is stored in the medium, you should remember. It is stored in sagum medium to increase the shelf life to 5 weeks at 2 to 6 degrees centigrade. Previously, the extra based medium is used. Now, sagum solution, you need to remember this solution. Instead of citrate based sagum solution, to increase the half-life to approximately 5 weeks. So next component is fresh frozen plasma. Fresh frozen plasma, it is used in coagulopathies rich in coagulation factors. So it is so you need to store it at extremely negative temperatures like minus 40 to minus 50 degrees centigrade. There's a 2-year shelf life. So fresh frozen plasma, it is the first line for coagulopathic hemorrhage. So FFP, it is used in case of isolated factor deficiency. So reversing warfarin therapy and correction of coagulopathies and antithrombotic therapies and thrombocytopenic purpura. So other things is cryoprecipitate, means it is a supernatant layer which is rich in factor 8 and fibrinogen. It is also the 2-year life. It is stored at minus 30 degrees centigrade. Platelets, pool platelet concentrate, it is stored in special agitator at 20 to 24 degrees. The major downside is that platelets can be stored for only a period of 5 days to 1 week. So you need to use this in a limited time period. So platelets which you could see in your in daily practice, platelets are mostly commonly used in dengue fevers with the coagulopathies. So there are two types of platelets. One is a pooled concentrate, and the other is a single donor platelet. Single donor platelets means blood cells from a single donor is collected, and it is of use in case of dengue fevers and all. So platelet transfusion is done in case of thrombocytopenia or platelet dysfunction. These are the patients who are bleeding, and prophylactically when the count is below 10,000 to 20,000. In preoperative patients, in surgical patients, we need to transfuse platelets if the platelet count is less than 50,000. So the bleeding, gum bleeding, and other manifestations of purpura and all, bleeding manifestations of low platelet count will be manifested, and then you need to get a platelet count done. Even in cases of dengue fever, when the count is less than 20,000 and the patient is having bleeding manifestations of bleeding gums and all, Then you need to transfer with the platelets. So, and the next is prothrombin complex concentrates. These are highly purified concentrates separated from the whole plasma. So these contain 2, 9, and 10. So this is for emergency reversal of patients on warfarin therapy in uncontrolled hemorrhages. These are the various components. Of these, you need to remember that FFPs are stored at minus 40 to 50 degrees centigrade, and cryoprecipitate also requires minus 30 degrees of temperature. So other factor-based therapies are used in case of factor-based concentrate therapies are used in case of factor deficiencies like hemophilia. And so, what is the definition of safe blood which is ready for use in any patient requiring transfusion? So, it is considered safe when it is donated by a carefully healthy selected donor. So, the donor should be free from infections which could harm the patient or which could be detrimental to the patient. So normally the donors are screened for HIV, HPSAG, HCV, syphilis, and all these potentially transmittable diseases through the blood, potentially transmitted sexually STDs, which could also be transmitted to the blood and blood products. They should be screened, and the patient should donor should be free from all these infections. It should be processed by reliable methods of testing, component production, and storage and transportation. Mostly, it should these process are to be done in a very stringent manner to avoid contamination and thereby causing any reaction to the transfused person. Transfused only upon need and for the patient's health and well-being. These are the prerequisites for a safe donation. So blood donation is very safe. You need to have a period of 3 to 4 months of gap before donating the time. So coming to the steps in blood screening, first is the physical screening for a blood donor donation. The patient at least should be more than 45 kilos of weight, and he should not be cachexic or malnourished. So good nutritional status and nutritional assessment should be done before blood donation. So laboratory testing, as we already discussed, we need to screen the donor for HIV, HPSAG, syphilis, and all. Syphilis VDR test is done commonly in our blood bank and all. So all these infective markers need to be assessed before screening. And cross matching. Cross matching means you might have already known, matching the patient's blood with the donor blood and looking for any incompatible reactions like under the microscope, like any formation of clumps of antigen antibody aggregates and all. So blood donor requirement. So in order to donate blood, patient should be in a good physical and mental health. His age should be between 18 to 60 years of age. Should not be less than 12.5 in males and 11.5 in females. Minimum weight of 45 kgs. And blood pressure should be systolic 100 to 140 millimeters mercury and diastolic 60 to 90 millimeters. The patient should not be febrile at the time of donation of blood. It should not exceed 37.5 degrees centigrade. The pulse rate should be normal of 60 to 100 beats. And we already discussed that in order to donate one more time, there should be a minimum gap of 3 to 4 months. One of the biggest misconceptions is the patient uh, the donor should fast before any blood collection. It is not at all true. The donor should not be fasting if the last meal was taken more than 4 hours ago. You need to eat well. The typically what we tell to the patient is donor should have a good night's sleep and good dinner and good breakfast before donating in the morning. So blood flowing into the back, it is mixed with anticoagulant in a ratio of 1:7. So total volume is 409 to 495 ml. Roughly 450 ml is donated, approximately 12% of total blood volume. Generally, in our blood banks, we bleed the patient for only roughly around 350 ml. So the maximum they could given is 400 to 500 ml. So autologous blood transfusion means this is useful in case of emergency surgeries, and autologous blood transfusion means collection and reinfusion of the patient's own. So suppose you are planning for a preoperative in a preoperative setup for an elective surgery, or in case of cesarean and other planned elective operations, you need to collect the patient's own blood, you need to store it, and then use it in the surgery. So this is known as autologous blood transfusion. So the types is preoperative autologous blood donation, acute normolytic hemodilution, intraoperative blood salvage. So there are certain people of there are certain groups of people who refuse, and they are adamant to blood transfusion, says it's against their mythology. So these group of patients in the western countries, there is a certain group known as Jehovah's Witness. These people, they don't allow for blood transfusion from others person. So in case of those people, you could use autologous blood transfusion. And the intraoperative blood salvage means in case of emergency surgery where there is more intraoperative loss of blood than anticipated, you could collect the blood, and there are separate filters available in the blood bank. You need to collect the blood, and the blood is passed through those filters to avoid any contaminants, and the patient's own blood is transfused to him. This is known as intraoperative blood transfusion. It is also done in cases where there is lack of adequate time for cross matching, such as in massive trauma and all. So the homologous or allogenic blood transfusion means a collection and infusion of blood donation from a compatible donor. So you need to remember these two terms. Autologous means patient's own blood is reinfused after collecting, and like acute normolytic hemodilution and all. So this is particularly useful in people, certain communities who refuse blood transfusion, such as Jehovah's Witness and all. It is also done when suppose when the patient's blood group is very rare, which is the Bombay blood group and all. Then also conditions of very rare, the patient is planned to have when elective surgery. Then also the autologous blood transfusion. Okay. So the homologous or allogenic blood transfusion means collection and infusion of blood of a compatible donor. So coming to the indications of blood transfusion. So one is the acute blood loss to replace the circulating volume and oxygen delivery. So in case of severe trauma where there is severe blood loss, so and preoperatively in case of patients requiring surgery, preoperative to correct the perioperative anemia and to ensure adequate oxygen delivery. So and in case of symptomatic chronic anemia in case of various diseases. So the thing is, so newer guidelines, previously it used to be more, and now the guidelines is if the hemoglobin is less than 6 gram per dl, the indication is patient probably will benefit from the transfusion. If it is 6 to 8, transfusion unlikely to benefit unless there is an impending surgery or ongoing bleeding. There is no indication of transfusion if patients are below 6 to 8. You need to assess since the patient's complete profile, ferritin and all, and rule out the factors causing severe anemia, and then you need to transfuse. So greater than 8 gram per dl, there is no indication of transfusion unless in the absence of other risk factors. So the main we already discussed. Carl Landstein discovered the blood group system in 1901. So the main systems being followed are, one is the ABO system and the other is the rhesus system. ABO system was discovered by Carl Landsteiner, and the other is rhesus system, which is whether RH positive or negative. So ABO system on antigen A and B or no antigens. You already know, you might have done it in your physiology practicals and pathology practicals. And the other is O blood group. O blood group is also known as universal donor, as it has no antigens. Depending upon the antigens, they are named as A, B, and O, and AB. So as there are no antigens to promote any immune-mediated inflammatory reactions, the blood group is considered as a universal donor. The AB group is known as universal recipient. Depending upon the antigens, these are known as A blood group as A antigen, B blood group as B antigen, group AB has both the antigens, and group O has no antigens. So the antibodies are group A has anti-B, group B has anti-A, group B none, anti-A and anti-B. So the rhesus D antigen is strongly antigenic. So these antibodies are naturally. So you need to remember this. You need to understand this also. The antibodies to the rhesus antigens are not normally present. Whereas in case of ABO blood grouping, the antibodies patient, as we already previously discussed. So the group A patient has anti-B, group B has anti-A. These are normally present. Whereas in case of if the patient is not prior sensitized, there is no patient don't have antibodies against the rhesus D antigen. So how the patients get sensitized or sensitized means, in case of the patient can have prior blood transfusion with a non-compatible D antigen, then the patient can be sensitized. Or in case of you also know these conditions of RH positive fetus in a RH negative mother, then also they could be sensitized. So these acquired antibodies, IgG antibodies, are capable of crossing the placenta, and if the mother is RH negative, can cause severe hemolytic anemia and intrauterine fetal loss. So, to prevent this, anti-immunoglobulin is given. So cross matching confirms the ABO and RH typing. It detects the blood grouping to other blood group systems, antibodies, and antibody screening is done by India Home test. Patient serum plus donor RBC plus home serum, that leads to red cell agglutination. So the rates of transfusion is important. You can't transfuse. Suppose it is whole blood, you need to transfer it at the rate of 150 to 200 ml hour per max. So whereas in case of PRBCs, it's 100 to 150 ml. Platelets and all 150 to 300 ml. So whole blood are packed red blood cells. You should start transfusing within half an hour before removing it from the refrigerator component where it is stored, and you should complete the transfusion in roughly around 4 hours. If the time exceeds, then discard. Whereas in case platelet concentrates, you need to immediately start transfusion, and it should be done within 30 minutes. Same with the FFP also, as soon as possible within 30 minutes. Cryoprecipitate also. So these components you need to administer within a period of half an hour. Whole blood cell, it's in packeted and cells, you need to complete transfusion in 4 hours. Coming to the transfusion reactions, so some are major and some are minor. Most of these transfusion reactions are due to, previously it is due to ABO incompatibility and anti-incompatibility. So unfavorable transfusion related after during or after the transfusion of blood components. Transfusion reaction, they could be either non-hemolytic or hemolytic. Hemolytic means immediate means it's ABO incompatible blood. This could be errors in labeling the blood group and improper cross matching of blood before transfusion, or human errors like misplacing the blood bank and transfusing to the wrong person. They could lead to hemolytic. This is delayed means hemolysis 1 to 2 weeks of after transfusion. It is due to reappearance of antibody against the donor antigens. Coming to RBCs, the non-hemolytic side effects, the causes are physical or chemical destruction of blood, freezing or heating, or it could be
This conference will now be recorded.
could be due to bacterial contamination of the stored blood. So the symptoms for the patient presents with the fever, chills, and urticaria. Treatment is you need to administer diphenhydramine and antibiotic for fever. So prior loading of the Decadron and all. You need to keep them ready before prior to transfusion of blood components. So the bacterial contamination reactions included. So mostly these are due to endotoxin production by bacteria, such as Pseudomonas, E. coli, and Yersinia enterocolitica. Clinical features roughly appear 30 minutes after transfusion. Clinically, the reaction is termed as warm and is characterized by dryness and flushing of the skin. The diagnosis is by the components are sent immediately to the blood bank along with the patient's blood for visual inspection, gram stain, and cultures. So the therapy includes due to bacteria, guided antibiotic broad spectrum therapy, which is administered intravenously. So if the patient is in introduction mediated shock, you need to remove steroids and vasopressors and organ-based support. Alloimmunization means delayed, it's non-hemolytic transfusion reaction. Even very small amount of donor antigen in RBCs, they can elicit an alloimmune response. It occurs due to exposure to foreign antigens by blood components. The clinical features are fever, there will be falling hemoglobin and hematocrit. So the diagnosis is through antibiotic screen test. So the immediate hemolytic transfusion occurs within minutes or within an hour of transfusing incompatible RBCs. The pathophysiology includes antigen of the RBC donor plus antibody. It elicits a neuroendocrine response causing complement and coagulation activity. Cytokines are released, which are responsible for incompatibility and hemolytic transfusion reactions. There are two types of hemolysis. One is the intravascular, which is in the vascular compartment, and the extravascular hemolysis. So the intravascular hemolysis, it causes release of hemoglobin, RBC chromata, and intracellular enzymes, which manifests as hemoglobinemia and hemoglobinuria. So the hemoglobin complex acts on kidney and causes hemoglobinuria, or it can present as hemocytopenia. The complex is catabolized by endothelial cells and bilirubin in liver. So other thing is extravascular hemolysis, which is mediated by antigen antibody complex. So here the RBC lysis does not occur intramuscularly. There is no release of free hemoglobin RBC enzymes. They are not released into circulation as it occurs extravascularly. So therapy is mainly focused on a preventive and supportive measures. Thorough cross-matching and thorough verification of the blood and processing can lead to significant reduction in this incompatibility and other immunological reactions. So the patient should be monitored for risks like DAC, hypertension, and hypertension. So for renal dialysis, mannitol is the agent of choice. So ethacronic acid and furosemide has been these are used to improve renal blood flow. So if the patient is in shock and hypotension, he is to be treated with IV fluids and pressure drugs. So the component therapy should be used in patients with bleeding dialysis or a significant coagulation abnormalities. The other is delayed hemolytic transfusion. It is most commonly due to secondary response in patient who is priorly sensitized by previous transfusion or pregnancy. Only secondary response to transfused RBC and primary albumin. So delayed hemolytic transfusion in reaction due to secondary response. The name itself says it is delayed. It takes about 3 to 7 days of time. So coming to the clinical features, so sudden or unexplained decrease in the hemoglobin or hematocrit, oliguria and dick are rare, disseminated intravascular coagulation. So investigations, you need to monitor the hemoglobin and hematocrit, coagulation studies, and the renal function tests. Therapy. The goal of the therapy is to prevent and treat severe complications of delayed anti-transfusion reaction. So, in order to maintain renal function test, the patient is supported with IV fluids. Symptomatic anemia is treated with the RBC transfusion. Whereas in case of WBCs, there are febrile reactions. The recipient antibody reacts with the donor antigens and stimulates the release of pyrogens. It is managed with antipyretics and slow transfusion. So one of the significant side effects and complications is TRALI. TRALI means transfusion-related acute lung injury. So it is also known as pulmonary hypersensitivity reaction and allergic pulmonary edema. So the pathophysiology is donor leukocyte antibody reacts with the recipient leukocytes, which activates the complements, and the tissue basophils and platelets release histamine and serotonin, which causes the aggregation of leukocyte emboli in the lung capillary bed, which results in transfusion-related acute lung injury. So these granulocytes they adhere to the pulmonary endothelium and cause release of proteolytic enzymes and toxic oxygen radical metabolites. So it leads to interstitial edema in the alveoli. The symptoms include fever, hypotension, tachypnea, vision will be dyspneic. If you saw an X-ray, there will be diffuse infiltration. So the clinical signs will be sized of non-cardiogenic pulmonary edema. The diagnosis, you need to obtain serum from both the donor and the patient, and they need to be tested for anti-leukocyte antibodies. It is rallies or a diagnosis of exclusion. You need to rule out other conditions before arriving at this diagnosis. So the treatment includes mainly it is respiratory support. So if clinical symptoms and signs are suggestive of transfusion, it should be immediately discarded and sample should be sent back to the blood bank for re-verification. So you need to provide adequate respiratory and hemodynamic support, giving fluids and respiratory support. So if it is caused by patient anti-leukocyte antibodies, then the therapy includes you need to administer leuko-reduced blood compound preparations It is caused by donor leukocyte antibodies. There is no special component preparation appear to be indicated. So one more significant apart from trial is TACO. TACO means transfusion associated circulatory overload. So it is an hydrogenic complication which could be very much in. So who are at risk? Patients who are at risk are children, elderly patients, and patient is the chronic non-hemolytic anemia. And children, depending upon their age and body weight, you need to administer blood. Excess administration can lead to circulatory overload. The clinical features are dyspnea, coughing, cyanosis, orthopnea, discomfort, headache, and tachycardia. Therapy means you should rapidly reduction of hypervolemic and circulatory overload and oxygen therapy, and to reduce the circulatory overload, you need to administer intravenous diuretics. Usual rate of transfusion is at 200 ml per hour. Coming to the difference between the Trally and TACO. So Trally blood pressure is low to normal, whereas this is circulatory overload, so the blood pressure will be normal to high. So body temperature is normal in cases of TACO. Transfusion associated with cardiac overload. Chest X-ray, there won't be vascular condition. Infiltrates can be bilateral pulmonary infiltration can be seen in case of Trally. Whereas in case of circulatory overload, there will be vascular condition and pleural. So B type natriuretic peptide, it will be low in cases of Trally and high in case of TACO. So the pulmonary artery occluding pressure is low to normal in case of Trally and high in case of TACO. Ejection fraction will be normal and TACO it will be abnormal. So response to diuretics, TACO will be improved because it is circulatory overload. Improvement in the increase in diuresis can lead to improvement of symptoms. The edema is transited in case of Trally and oxidate in case of TACO.